We're in good shape.
Okay, good. Well, sorry for the delay. Thanks for being here, Dr. Parks. So Dr. Ted Parks is orthopedic surgeon at Western Orthopedics. Very glad to have him back. Now, my understanding is that originally you were planning to be a biology teacher.
Still am. So just on my way to be a biology.
Yeah, okay. So my for that is the medical school is agency at UCLA, and a fellowship in Cincinnati with Dr. Frank Noyes. We've been grateful to have you as a lecturer for many years. Dr. Brooks has lectured at both the state and national positions. And we're just very delighted to have you back. Thanks for being with us.
Yeah, great. I'm ready to be here. A little nervous. What I have on my slide is different from that. Let's just go ahead and see what happens. So, go back a slide, please.
Yeah.
Use
That's something I'm less concerned about you getting today because we'll do a whole bunch of that too.
Okay.
But it's nice. Yeah, I think he simplifies things. That's very understandable for students and residents.
All right, before John, one of the challenges I have is I'm used to teaching one.
Ted, no, you're muted. Ted, I think you're muted. Ted.
Yep.
There you go.
All right, thanks. Coming off mute now. The first part's supposed to be muted. That's on purpose. So these are my financial disclosures. I have none, but if anybody out there wants to give money, I'm totally up for it. Let's go to the next slide. All right, I do get there we go. I do get some money every time one of these is sold. This is a book that I wrote for McGraw-Hill, and yeah, so I guess that's a disclosure of sorts. But let's get started. We've got a lot to cover here. Next slide. And we're going to start with anatomy. I'm going to do my best not to bore you with the anatomy. We'll do a little bit of it, but if we don't have the anatomy down pat, it's really hard to get the rest of the talk. So we're going to start with the structures deepest in the shoulder, the three bones. Next slide. And the three bones are the scapula, the humerus, and the clavicle. And if I shut off the slide projector and ask you guys to draw these bones, I think everybody would do okay on the humerus. It's just a sort of a rod with a ball on top, and the clavicle, which is sort of just a S-shaped rod. But we'd have a hard time drawing the scapula. So I'm going to do a couple slides just to go over the scapula anatomy a little better. This slide, next slide. Great, thanks. So this is a slide that just shows how you would look at the scapula from a couple different views. On the far left is the posterior view. And when you look at the scapula from the posterior view, the main thing you see is this bar, this sort of ridge, or this is the scapular spine. And that's a piece of anatomy that's really important. On the posterior part of the scapula, you can feel it on yourself. And even on the heaviest patients, you can feel it subcutaneous on everybody. The next view is turning this to 90 degrees. So, so I can go back the other direction. Actually, stay right there. The middle slide shows what the shoulder would look like if you're looking directly lateral at it. And the scapula, the feature on the scapula you see best on that view is the glenoid, the socket of the ball and socket joint. And then we'll turn 90 degrees, so now we're looking front. That's the one on the far right of those three pictures. And now we're looking at the scapula from the anterior view. And the feature that's most prominent there is a little process called the coracoid process that sticks out towards you like a sort of bent pinky finger. And that's just the attachment site of a bunch of muscles and tendons. So that's the scapula. Let's go to the next slide. These three bones make two joints. So already things are getting confusing. We're supposed to be talking about the shoulder, and there are actually two shoulder joints to talk about. There's actually three, but the third one is very, very obscure. The first two are important. The glenohumeral joint, which probably gets most of the publicity, that's the ball and socket joint of the shoulder. And then the little joint between the clavicle and the acromion, the AC joint. So if we go back to the scapular spine, we looked at the scapular spine a second ago, this ridge on the back, it's sort of shaped like a hockey stick. And the blade of the hockey stick here, that's the acromion. And we're looking at the acromion from the front here. The third joint is the articulation between this whole thing, between this whole shoulder girdle and the chest wall. So this actually sits against your chest wall like this, and it moves around. You can make yourself do that. And there is pathology in that articulation, but it's pretty obscure. So we're going to skip that and just assume that there are only 2 shoulder joints for the rest of the talk. Anytime you have a joint, you need a system of ligaments to hold the joint together. Let's go to the next slide. And this slide just shows those joints. Let's look at the glenohumeral joint first. There's a structure called the capsule. This is a membrane that goes 360 degrees around. It holds the fluid in the joint. And in the wall of the capsule, there are fortified bands that we've given names to all of them. I used to memorize those names for the tests that I would take in orthopedics. That's a little crazy, but the concept is valid. There are bands of fortification in the capsule wall that are pretty reproducible from person to person. And those bands are strong enough if you push your shoulder past where it wants to go, to get tight and they keep it from dislocating. But they're flexible enough that you can put your arm to the full range of motion. So now go up to the little AC joint, and you'll see that there's a similar system of ligaments in the capsule of the AC joint, little fortifications in that little capsule that hold that joint together. And those are the ligaments that hold those joints together. Let's go to the next slide. So this is the deepest layer of muscle. Now we're at the rotator cuff muscle, and there are 4 of them. At least the textbook says there are 4 of them. From here forward, I'd love you to think about it as just being 3 of them. There's the 4th one that really has no clinical significance. If you were born without this 4th one, you wouldn't even know it. And there's no way to really, it doesn't really act up on this. So we're going to talk about those muscles more specifically. We'll start by looking from the front of the shoulder. Next one. So this is an anterior view. We know that because we see the little coracoid, the little bent finger pointing at us. And the muscle that's on the front of the shoulder is called the subscapularis. It's on this model too, but let's use this slide. It's really hard to see this model, I think, for you guys, and hard for me to keep it in the right position. So the subscapularis originates from the scapula and goes out and inserts on the humerus. Then we're going to flip the shoulder around and look at the back side of the shoulder. Next slide. This one is the infraspinatus. The one beneath it is the teres minor, and it's the one I think we can forget. So let's just get rid of that. Next slide. And assume that from here on, there are only 3 rotator cuff muscles. The one that's hardest to see when we look from the front or the back is supraspinatus, because it lives up on the top. So let's go to the next slide. You can look down at somebody from the ceiling. And if you look down from the ceiling, you can see the supraspinatus. It tucks underneath the acromion, the blade on the hockey stick, which you can see in the drawing on the right. So infraspinatus is in the back, subscapularis is in the front, and supraspinatus is on the top. And those are the only 3 that we really need to think about or worry about. Let's go to the next slide. This is the next layer of anatomy. This is the bursa. And a bursa is a really interesting piece of anatomy. It's a plum-sized little bag that is deflated. Think about a plastic bag that's collapsed with a couple drops of 30-weight motor oil in it. The slimy synovial fluid inside that bag lets surfaces glide against each other. So it's nature's version of a bearing. And anytime you have tissues that rub against each other with friction, nature puts a bursa there. So there's a famous one over the point of your elbow. That's important because the skin there has to really glide over a long distance over a hard piece of bone. So we have a bursa there. They're all over the body. Oops, let's go back, please. And if we, as a repeat, is put in hardware that's prominent, like a screw that sticks up, the body will actually put a bursa over that. If you take these bursas out, they grow back. So your body's good about putting bursas where they need to be. So we're almost done with the anatomy. Next slide. The final layer is the deltoid muscle. And one of the things that's changed a lot since I was in residency is our concept of how the rotator cuff and the deltoid muscle work together. When I was in school, in residency even, we were taught that the purpose of the, just we can back the camera out if you want. I'm not using the close view. We were taught that the purpose of supraspinatus, rotator cuff muscle that lives on top, was to abduct the arm for the first 30 degrees. The first 30 degrees of abduction was the purpose of this perfect thing, so supraspinatus. And that's totally wrong. And there are a couple things about that explanation that didn't make sense. But one reason we thought that is that if somebody had a rotator cuff tear of the supraspinatus, and supraspinatus, we'll see in a minute, is the rotator cuff muscle that tends to get torn most often. If somebody had a complete tear of supraspinatus, they lost the ability to abduct in that first 30 degrees. But if you could get them past 30 degrees, they could raise it up after that. And then if we fix that supraspinatus rotator cuff tear, voila, they could do it on their own. We saw that over and over and over again. So we just assumed that's what that muscle did. Doesn't really make sense because the deltoid, which is the abductor of the shoulder, is 10 times bigger than the supraspinatus. And you should be able to do everything you need to do with just the deltoid. But we kind of ignored that flaw and just marched on deciding that that's what it did. To understand what it really does, you need to understand 3 very basic biomechanical principles. Next slide. The first one has to do with the shape of the socket. So here are 2 ball and socket joints, the shoulder glenohumeral joint on the left and the hip joint on the right. And the socket in these 2 joints is very, very different. The socket in the hip is more like what you think about as a socket. It's a deep bowl that the ball sits in. It really captures the ball and holds it stable there. The socket of the glenohumeral joint is very shallow. It's like the surface of a golf, just a little dimple that the ball sits across from. And there isn't much geometric stability there because the socket is so shallow. Let's go to the next slide. The print is coming off kind of weird there. The next slide illustrates that the deltoid muscle, when your arm is at your side, the deltoid force vector is essentially vertical. That deltoid muscle contracts and brings its insertion close to its origin. It's basically pulling the humerus straight up. And then the last thing we have to understand is that the attachment of that deltoid is on the lateral side of the humerus. Next slide. I'm just showing that it attaches way out on the lateral side. The humerus about a third of the way down toward the elbow. So now let's look at a theoretical elbow or a shoulder joint. Next slide. This is a shoulder joint that doesn't exist. This is a shoulder joint that would be if we had a socket like the hip. We had a socket that really captured the ball. That little plus sign is the center of rotation, and the black arrow is the deltoid force vector when your arm is at your side. So if our shoulder looked like this, and we fired off the deltoid contraction, the deltoid would try to shove the humerus straight up, and it couldn't because there's bone above it. And because there's bone above it and it couldn't go up, and it's being forced, and the force is being applied lateral to the center of rotation, you would get rotation. Next slide. But our shoulder wouldn't look like that. Our shoulder looks like this. Next slide. So that's what we have. We have a very shallow socket with no bone superiorly. So if we fire off a deltoid contraction, next slide, that's what's going to happen to our shoulder. The ball just goes up. That socket won't hold it. If we abduct the shoulder 30 degrees, you can take the next slide. Then the deltoid contracts. It pulls the humerus medially and superiorly, and the socket's right there to stop it. So you will have, if you're past 30 degrees of abduction, and you fire off a deltoid contraction. So what we learned about the rotator cuff is that it's really, next slide, a whole bunch of little force vectors that help suck the ball into the socket. And if the rotator cuff is working and it's holding the ball against the socket, then that little lip at the top of the golf tee dimple there is enough to keep the ball in the socket. So all it really does is establishes a rotation pivot point by holding the ball in the socket and letting the bigger muscles of the deltoid do their job. So that's really how the rotator cuff, at least what we think now, is how the rotator cuff and the deltoid interact. And it explains a lot of pathology we couldn't explain before. So enough of all this, let's pretend like we're seeing patients. I would propose to you that 90%, next slide, of every patient, oh, that's a shame. Well, slides are really coming out great here. So there's a whole bunch of stuff on this slide that you're not seeing, but that's okay. 90% of the patients that will walk into your office with shoulder problems will fall into one of these buckets. And since we don't have a lot of time, we'll definitely spend all the time we can on the first bucket, impingement, just because that's about 70% of them will fall into that bucket. So for sure, the most common thing you'll see if somebody comes in with shoulder pain is impingement. So we'll really get into that topic, and we probably won't have time for much of the others. We'll see. Next slide. So to understand rotator cuff impingement, we really need to understand this subacromial space. And this is where the model would come in handy, but it doesn't show up that great on the camera. So we'll try to use the slides to explain it. This next slide, hopefully is looking, starting to look familiar. You can see, let's see, if I point to that with my hand, there you want to see that, right? Okay, all right. So I'll just have to imagine that you're following along with me. You can see the head of the humerus, and you can see it across from the glenoid. And then the thing right above it is the supraspinatus muscle, which as you go laterally turns into supraspinatus tendon. And then above that, you can see the acromion bone. Oh, great. Is that a little enter? It does. Yeah, great. Thanks. That'll help a lot. Thank you. Great. Oh, this is great. Okay. So here's supraspinatus muscle. This is the supraspinatus tendon. And look how far it attaches, way over here laterally. And then above that is the acromion bone. This is the clavicle. That's the acromioclavicular joint or the AC joint. And this is the bursa. That's way more like what a bursa looks like. It's not blue like that other slide, and it's not all up. It's collapsed, like the sac that's collapsed. And the British like to call it the subdeltoid bursa. We like to call it the subacromial bursa. It's about half of it under the acromion, about half of it under the deltoid. So we both are correct. Let's go to the next slide. We're looking at the exact same thing, only 90 degrees shifted. We're looking as if we're looking directly lateral. And the artist has made the humeral head transparent, so we can see the glenoid underneath it. This is supraspinatus on the top, subscap, remember that's in front, infraspinatus in the back, and we don't have to have any teres minor. Next slide. Great, let's get rid of that. So what happens in impingement, next slide, is that the structures that live underneath the acromion bonk against the acromion when the arm is abducted. And this is something that I wish I could show you better on the model. That space here underneath the acromion is wide open when the arm's at your side. But as you raise your arm over your head, the space gets narrower and narrower. And if you're unlucky, you can start to pinch the structures that live under the acromion against the other side of the acromion. And there are three things that live under the acromion. Two are illustrated on this drawing. One is the rotator cuff. And because the supraspinatus lives on top, it's way more apt to bump into that bone than any other rotator cuff muscle. It spends way more time under the acromion than subscap in the front or infraspinatus in the back. So it's definitely something that can bump against the underside of the acromion. The other thing is the bursa. Here's the bursa bumping against the underside of the acromion when this person abducts to about 90 degrees. The third thing isn't shown on this model, or on this drawing. Yeah, next slide. We lose it. It's great. So the third thing is the long head tendon of the biceps. Let's go to your next slide. Just shows it a little closer and a little clearer. So the biceps got its name because it has two attachments. And I don't know how we came up with this, calling one the short head and one the long head, because they're about 1 millimeter difference in length. But that's the name we use for them. And the short head, it goes over here and attaches to the coracoid. Remember that little finger-shaped thing that points out to the anterior part of the body. The long head goes up underneath the acromion. So it's something that can be rubbed against the underside of the acromion when you abduct your arm. So I don't know how many people have seen this person in the office. Next slide. But this is somebody that has ruptured their long head biceps tendon. And that typically happens because the long head biceps tendon has rubbed over and over and over again against the acromion and gotten thinner and thinner and thinner. And then something usually pretty trivial, lifting something that you may have lifted 100 times before, is the straw that breaks the camel's back. And that tendon ruptures and you get this deformity, which is kind of cool looking actually. But the neat thing about this is we don't have to fix this. We don't fix it because the functional deficit is trivial. People lose about 5% of elbow flexion strength, which is not really making a material difference for them. And the reason why the strength deficit is so little has to do with the fact that this is a very unusually shaped biceps compared to other biceps in our bodies. Let's go to the next slide. So this is a couple of biceps muscles. The one on the left is more like the biceps femoris of your thigh, your hamstring muscles. And in that system, if we were to lose one attachment, let's say we pop that attachment, we'd probably lose close to 50% of the strength of that system because we're losing all that muscle. But our biceps in our arm looks like this. And if we lose this attachment, most of the muscle can still exert its force using the remaining attachment. So the functional deficit is trivial when you pop a long head biceps tendon. We never ever really pop the short head biceps tendon because it lives in a pretty peaceful, harmonious place attached to the coracoid process. It's the long head that gets into trouble because it's under the acromion and rubbing against the acromion and has attritional changes over time. Next slide. So that's the story with the third member of the subacromial space, the biceps. Next slide. Great. So I think it's helpful to think about impingement on a sort of a continuum basis. Least severe, earliest form is bursitis. So in bursitis, the thing that's getting pinched against the underside of the acromion because we abduct our arm is just the bursa. Rotator cuff is fine. Next, it goes on a little farther. Biceps and or the rotator cuff will get irritated, but not torn, just red and inflamed. And the trouble with all these things is the space in there is very tight. So if anything happens to make these muscles inflamed, their size increases and their edematous. The bigger they are, the more they bump, and the more they bump, the more they get swollen. So I always tell patients, it's like when you bite the inside of your cheek. The more you do it, the more you're apt to do it because it keeps getting swollen, which makes it get in the way more. If it happens long enough, then those structures can actually tear. And one of the things I always show is that in the model, I've been showing this so many times in this little model that it's actually starting to degrade and tear. So it's a great example of what happens if you rub it against the bone long enough. It gets thinner and thinner, and then like I was saying before, one day you do something that you've done a million times before. Maybe it's a big bag of trash and you can put it in a dumpster, and something tears, a biceps or the rotator cuff or both. And you'll see on this continuum, there's a thing that's way over to the right, cuff tear arthropathy, and it's the most rare of these things, but it's certainly out there, and you'll see it. And let's talk about it a little bit. It's really interesting. This is an X-ray now. Next slide. And hopefully this stuff is starting to look familiar. Here's the head of the humerus, the glenoid. This is the clavicle. So that's the AC joint right there, that dark gap. And this is the acromion. So my pointer is in the subacromial space right now. And on this X-ray, we don't really know what's going on there. It could be totally normal and healthy. There could be a rotator cuff tear. It could be rotator cuff inflammation from the plain bursa. All those things are soft tissue things. So we can't really make any judgments about what's happening in the subacromial space on a plain X-ray, at least not this plain X-ray. So take a mental photograph of that, and then let's go to the next slide. So here's a different patient, clavicle, AC joint. This is the humerus. That's the acromion. I think you can appreciate that the space between the acromion and the humeral head is essentially gone. And the humerus has actually ground itself a little socket-shaped concavity in the underside of the acromion. We know for sure, just with this X-ray, that this patient has a rotator cuff tear. There's no way that the rotator cuff, which is a 1 centimeter thick slab of steak, is going through that tiny little space and making it all the way to the vertebra. So if you had to guess, can anybody tell me whether they would guess whether this tear is small or big? It's big, yeah, it's huge, because the best case scenario is the leading edge is right here. It's supposed to be all the way over to here. So that's a massive, massive tear. And if you had to guess if it's acute or chronic, what would you guess? It's chronic, yeah, because it's already machined away a little concavity on the underside of the humerus. So this is one of the things that we swept under the table in our old model, 30-degree abduction model, because you would think in that model, if you lost supraspinatus, torn big tear like this, the humerus should fall down. That muscle's on top. If you cut it, the humerus should drop. But all the time it went up. And it goes up because without that rotator cuff force vector holding the ball in the socket, even the resting tone of the deltoid will bring the humerus up. And every time this patient's tried to raise their arm, the humerus has gone up and ground away against the underside of the acromion. So this totally is easier to explain with our new model of how things work compared to our old model. Next slide. So this is just looking from above. And the reason I wanted to do this next slide, we're going to do a little high-tech, another slide. So this is, we're going to do the next 3 slides, 1, 2, 3. Go ahead. So this is abducting the arm. Go ahead. Keep going. Keep going. Keep going. So that dot shows where the rotator cuff or the occupants of the subacromial space are going to contact the acromion as you abduct your arm. Next slide. Let's put the rotator cuff in there. Next slide. So that black dot is actually where rotator cuff tears originate, because that's the spot when you abduct the arm that rotates up to bump against the acromion. Next slide. Right, so that's a typical rotator cuff tear. Next slide. And that's a bigger rotator cuff tear. And the one we were looking at is even bigger than that. And those little arrows are the force vectors that are pulling the rotator cuff open. So these aren't likely to heal by themselves because the muscles are actually pulling that guy open and keeping the edges of the tear from healing. Next slide. So this is, like you guys thought, this is a chronic massive rotator cuff tear. And I always tell patients when you wear out your rotator cuff, it's like wearing out the decal on your jeans. It starts with a little bit of rubbing, things get kind of fuzzy, and then one day you can see through there. That's when you've got a full thickness tear. And this tear, this extreme example of a tear, a big chronic massive tear, is like my daughter's pair of jeans. Next slide, which she paid extra for that. And in this rotator cuff tear, we actually have missing material. There's an area of material that's gone. And the edges of a rotator cuff like that look exactly like that. They're just frayed and nasty. They wouldn't hold a stitch. If we were going to try to repair that, the first thing we'd have to do is trim out all that stuff around the edge. It's going to make this defect even bigger. There's just not enough physical material to bring the edges together. Now, for the jeans, you could put a patch on that. My daughter would kill me, but I could put a patch on that. You can't really do that for the rotator cuff because remember, for the rotator cuff to do its job, it has to be contracted. And a patch is a dead piece of something. When we put it on there, it looks really cool. It looks like we built the whole thing and everything looks great. But since it doesn't contract, it doesn't do what the rotator cuff has to do, which is hold the ball against the socket. So every 5 or 10 years, orthopedic surgery comes up with a new patch for the rotator cuff. And we do a bunch of them and they don't really work. And there's actually one floating around right now. But he's very surprised that we really did the job because again, it needs to be contracted muscle tissue. Next slide. So when I was being trained, this rotator cuff tear, next slide, which really is a chronic massive rotator cuff tear. You can see a more typical rotator cuff tear here than this one we're talking about, which is huge and no way to bring that over to there. Next slide. We didn't have a solution for this. Some people tried to treat this with a shoulder replacement. Next slide. And a shoulder replacement worked great for arthritis. This is an artificial surface of the ball. That's a plastic socket liner here and a stem to hold the ball in place. But if you do this operation on the patient we're talking about, as soon as they wake up from anesthesia and their muscle tone comes back, next slide, that's going to sublux straight up. The forces of physics are exactly the same on an artificial shoulder as they would be on a natural shoulder. So putting a shoulder replacement in there doesn't help, at least not that kind of shoulder replacement. So one of the things that's also changed since I was in training is something got invented that helps these people, and that's called the reverse total shoulder. Next slide. It's a really neat idea. In the reverse total shoulder, the ball is on the scapula. So we bolt this ball onto the glenoid backwards, and then we put the socket on the humerus. So flip-flop the way that nature has it. And let's take the next slide. This is an X-ray of what one looks like. And we're missing a key point here because the plastic piece that snaps onto here isn't visible. So next slide, I'm going to draw that. So that's what's there, you just can't see it, the plastic cup that snaps onto that stem. So now think about, next slide, what happens when you contract the deltoid. The humerus can't go up, the ball catches it and it rotates. So you can have a rotator cuff deficient shoulder and have this device inside and you restore function. So this is a really neat idea, a novel way to solve that problem. And that's what the reverse total shoulders does, and it's most useful for these chronic massive rotator cuff tears and what we call a pseudo-paralytic shoulder, a shoulder that a patient can't raise as the rotator cuff that is gone. Next slide. So now let's pretend we're back in the office and we're seeing patients, and we use the same tools that you guys do, history, physical exam, and studies. So on history, really the one that I want you to remember more than any other, and it makes total sense, is that these patients will have pain with overhead positioning of their arm. And that's the position that closes the space between the rotator cuff and the occupants under it. And so whether you've got bursitis, or rotator cuff tendonitis, or rotator cuff tear, or even that the big extreme example we just went over, bringing your arm up overhead will recreate the symptoms. The other things are all true, but they're harder to remember because it's not intuitive. So just remember the first one. Next slide. So now we'll talk about the physical exam, and I want to demonstrate that. Brandon, do you mind coming up? Try to stay in the cameras, because I think if we work right here, we'll be good. And we're going to stand, yeah. Let's see, I guess we'll go this way for me a little more. It'll center you up. Let me just move you around. Yeah, it's backwards from what we think. Okay, right there is perfect. So one of the things that's awkward is when I examine patients, I usually am right in front of them, so that's going to block everybody's view. So I'm going to do kind of awkwardly off to the side. So all I know about Brandon is that he has shoulder pain. Right now, I haven't really put him in any of the buckets that I said that these people will fall into. So let's say it's this shoulder. The first thing I'm going to do is a little palpation. And I'm going to start here. The sternoclavicular joint is actually another part of the shoulder, but it's not often in pathology. But I'm going to start there. And the cool thing about the clavicle, the sternoclavicular joint, and the AC joint is they're covered by a tiny thin layer of skin. So if they're angry and inflamed, you can light them up really easily by just pressing with your thumbs. And some of the stuff we do is irritating to people anyway. So you always got to do both sides. And it's only relevant if one side is much more uncomfortable than the other. So when I start this clavicular joint, I'm just going to walk my way out the clavicle. Clavicle is really easy to find on anybody. And then I'm going to go to the next kind of bumpy thing, which is the AC joint. And that's pretty easy to find too, because it's a prominent little knob there. And he's not being tender over any of those things. I am pressing here now, not at the AC joint, down a little bit farther inferiorly, sort of over just the front of the humerus. It's not critical exactly where. Imagine a silver dollar sign spot here, anywhere on there would be fine for palpation. And what we're doing there, I'll try to show this model. It's going to be tough. That black dot we were looking at where rotator cuff impingement occurs, it's hard to examine because of the acromion, unless you bring the arm behind him, which rotates it out to the front. So it's uncovered by the acromion now. We can press on it. So that's why I bring the arms behind the back to help rotate that spot forward where we can palpate it. So let's say that when we do that, Brandon does have pain here and not here. So that's a clue for me, thinking maybe we're on the impingement pathway. Next thing I'm going to do, I'm going to take his arm. I'm going to passively, meaning I'm going to do the motion. He's just going to lay back and relax and look handsome. I'm going to bring this up. And if it recreates his pain when I get to 90 degrees, either in forward flexion that way, or abduction that way, or anywhere in between, if I bring him above where his arm is pillowed to the ground and that recreates his pain, that's a sign that he has impingement. So that's another clue, and let's say that that is true. And then the next thing I want to do is I want to assess his rotator cuff strength. And this is a little bit complicated, but I'm going to have you hold your elbows against your side, right? And then I'm going to have you push out against me. Good. So what I'm doing there, I'm checking his ability to do external rotation. Okay. And if you had to guess, looking at the model, this is kind of an unfair question, but which rotator cuff muscle would you guys guess we're testing if we're rotating the humerus externally? Infraspinatus is correct. Yeah. So just remembering that the muscles, when they contract, the origin and insertion get closer to each other. So here we are. This is showing up or not, but on the posterior part of the shoulder, as you contract, it's going to rotate the humerus externally. And by the way, if you don't remember the rotator cuff muscle names, they are totally obvious. The scapular spine, the one below it is the infraspinatus, the one above it is supraspinatus. And if this were on a skeleton plastered against the chest wall, we would know that the only way to see the subscapularis is to peel the scapula up and look under it. So a subscapularis, it even tells you where it is. And what's even cooler is the teres minor, which is a minor wall and everything, its name tells you that what it is. So the names will tell you what they are. So perfect. We just tested infraspinatus, external rotation against resistance. So now I'm going to have you start in the same starting position and push in toward the middle. So now we're doing internal rotation. Any guesses? Which rotation? Subscap. Yeah. So infraspinatus and subscap are kind of mirror images of each other. One's on the back, one's on the front. They do the opposite things of each other. And there are some more accurate ways to test subscapularis, like lift-off test and the belly press test. But let's skip those. Just keep it simple. One of the things that I've learned teaching residents is I'll often have a shoulder patient and say, why don't you examine this one and then tell me what you think. And a couple hours later, I'll have to call security to get them out of there because it's orthopedics is guilty of this. We have so many tests for shoulders that are have different people's names and after you get done doing them all, you just are kind of lost in this quagmire of murky nonsense. So I'd way rather tune that down to just some real simple tests that you can do in the office, and they're really meaningful. So think about external rotation and internal rotation as tests of infraspinatus and subscapularis. And the tough thing about our science for a long time is that those were the only tests that everybody could agree upon. And that's a shame because the one we needed to test the most important one was supraspinatus. Remember, it lives under the acromion more than everybody else, so it gets in trouble way more than everybody else. We had like 13 different tests for that, and everybody argued about which one was the best. Until a guy named Job in Los Angeles took all the tests that everybody were doing and put electrodiagnostic needles into the supraspinatus and found out which of the tests actually excited supraspinatus the most. And of the winners, he excluded the ones that just kind of excited everything in the neighborhood. And the winner was this empty can test. And that's the test where you put your hands out, thumbs down. And you go ahead and do that. Good. And it's best not to do it parallel to the ground. It'll bring you down about that far. and push up toward the ceiling. You can do it straight ahead or off to the side a little bit, up toward the ceiling. Good. And let's say for Brandon's test that all of his rotator cuff strength tests were awesome. He was able to do them all, and they didn't hurt him. Okay. So I thought he had impingement, and I still think he has impingement. And I'm going to try to put him on that continuum of diagnoses. And for him, I think he's got bursitis, because if he has bursitis, it's going to hurt when he raises his arm up. That's going to pinch the bursa under the acromion. It's going to hurt when he brings his arm behind his back and I press on that impingement neighborhood. That's not a really specific thing. I'm pressing on the rotator cuff, the bursa, and the biceps, the whole neighborhood I'm pressing on. So it tells me he has impingement. But if his rotator cuff had tendonitis or a tear, he should have some pain and weakness. And the critical thing here is we test the rotator cuff with your arms at your side. Because with your arms at your side, the space is open, the bursa is not being pinched, rotator cuff's not being pinched, nobody's being pinched, everything's calm and happy. And the rotator cuff, if it's happy and normal, will exert itself. You can externally rotate, internally rotate. And even this test, we do it with the arms a little bit toward the ground to open the subacromial space. The only reason he's got pain is when we bring him up, he's pinching the bursa. And if we tested his rotator cuff up, with his arms up, he'd perform poorly because the bursa is hurting him. So we can get misled into thinking that there's a rotator cuff tear when there's not. So his exam helps me without any special tests to put him on that continuum as a bursitis patient. But let's say exact same thing. And this time we're doing all those tests. And on the empty hand test, we'll just show that one more time. This time it hurts him and he's weak. Okay, so now I know he's at least a step farther on that continuum. He's got organ bursitis. The supraspinatus member of his rotator cuff muscle group is sore, so sore that it's performing poorly when I test it. I don't know yet if it's got bursitis, if it's got rotator cuff tendonitis, that would make him perform poorly, or if it's torn. And if you really want to know more about it, you can give him a subacromial space injection. And you can use just lidocaine or a combination of lidocaine and cortisone, which will give you a little bit of treatment afterwards too. And after a minute or two, we can retest it. And if we retest him, and the pain goes away, because we just bathed that whole subacromial space with lidocaine, the pain goes away and his strength returns, and I'm going to say that he likely doesn't have it. Okay? He had his rotator cuff, if we opened up and looked at it, would be like a quarter-sized, angry red swollen thing. It hurts, and it's not cold. If the pain goes away and the weakness persists, that argues that he has a tear. And so real simple stuff without any fancy, equipment. We can do those tests. Thanks. So that's the physical exam. Next slide. And let's just try to go over those in detail. Resistant internal rotation subscap, resistant external rotation infraspinatus. And they call it Job's test. I should get rid of that. I should call it the empty can test, because that makes it so much easier to remember what it is. So think about it as an empty can test, even though we like to give a thumbs up to Job for figuring that out. Next slide. X-ray wise, this will pass this. We're running out of time. And there are X-rays, but you guys don't have to do these. The X-ray, if you want to get an X-ray, is called the Y view. Next slide. And it just looks up under the acromion. Next slide. And once in a while, you'll see these. It's natural for humans to build calcium on the underside of the acromion as we go through life. And that narrows an already narrowed space, which is why so many people after 50, 60, 70 years old get impingement. We tend to narrow that space even more. That's a real bayonet-looking bone screw there. You can understand how when you raise your arm up, rotator cuff, bursa, and biceps bump against that, that would hurt and even cause tissue damage. Next slide. What about an MRI? You're probably over MRI people. The MRI is a really attractive test because it's very sensitive and specific. Next slide. This is looking at what we saw before, that diagram of a cross-sectional AP. And this slide shows rotator cuff muscle coming over, all the way over uninterrupted and attaching here. And this shows supraspinatus. And this white gap is a space where the rotator cuff tendon is lost its continuity. There's a gap or a tear in it. Next slide. This just shows impingement. This is without a tear. Supraspinatus coming over, transitioning into being a tendon. This is where it attaches. And this is the acromion here. And you can see it's, it can almost look like it's being pinched right there. This is with the arm by the side and it's still tight. And when the person abducts their arm 90 degrees, remember this is going to rotate. And this inflamed edematous dot, that's a bunch of fluid in the rotator cuff attachment, that rotates the bonk into that. So this is the impingement, this versus that in 90 degrees of abduction. That image is taken with the arm at the side. What about treatment? Next slide. And I kind of do it in 3 stages. First stage is oral anti-inflammatory medication. Purpose of it is just to bring any inflammation out of that system that we can. So if the bursa is inflamed and swollen, if we can bring its size down a millimeter or two, this is kind of a game of millimeters, then we may be able to decrease the dimensions enough that we can help them with their impingement and get rid of it. Then also physical therapy along with those oral anti-inflammatory medications. You have to be a little careful. If you just send to physical therapy with an eval and treat to a generic prescription, the therapists, many of them are way good enough to figure this out, but they may have the patient do a famous physical therapy thing, which is walking the wall with their fingers to restore their motion. And every time this patient brings their arm above 90 degrees, they're mashing on the inflamed thing. So this is like biting your cheek on purpose when you're trying to get that bump to go down, not helpful. All right, so the much better, next slide, is to give them some instructions. Number one, give them the diagnosis. We think it's left shoulder impingement. We want them to do range of motion exercises, not overhead stuff, at least not until those symptoms resolve. We want them to teach good posture, which is the scapular retraction, which is pulling your shoulder blades back. So it's kind of anti-slumping, not a big slumper. But if you can pull your scapula back on both sides, cadaver studies have shown that opens the dimensions of the subacromial space. And then the next line, which is in physical therapy speak, is internal rotation and external rotation progressive resistance exercises. So strengthening exercises of internal and external rotation with your arm at your side. Important that be done down, so you're not impinging. That helps because, next slide, both the infraspinatus and subscapularis have a little bit of a downward pull spectrum. So if we can tone them up, bring the humerus down, we're going to help things out by pivoting the subacromial space. And remember, when the rotator cuff gets sick and non-functional, the humeral head goes up, which complicates impingement. So toning those muscles can help by bringing the head down. So let's say they do that for a month, and they come back saying that they're not better. Next slide. Then I like to use a subacromial space injection. This is an anti-inflammatory cortisone injection in the subacromial space. We can put lidocaine in it and test them to understand better where they are on the continuum. The purpose of this is, again, just to shrink any swelling that's happening in that subacromial space to lead to contact-free motion without impingement. And it's a good tool to have. Next slide. This shows a technique that I like. You can also inject posteriorly. It works just as well. We won't go over the details of that. Next slide. But after the injection, you'll have one of 4 outcomes. One is they get better and stay better, and that's done. We're good. And they may have a rotator cuff tear. People with rotator cuff tears, they can strengthen the muscles around the torn muscle, can be asymptomatic. And if you look at sort of like lumbar disc bulges or disc herniations, if you look at people in their 60s and 70s and just make 100 asymptomatic people get an MRI, we find all kinds of rotator cuff fraying, rotator cuff tearing in asymptomatic patients. So we know that we don't have to fix a rotator cuff tear just because it's torn. If we can get the patient asymptomatic without a surgery, it works. And one of the ways to get there is a cortisone shot. Let's say they get better. Next scenario, line down there, they get better for a long, long time, but they come back, let's say in 6 months, because they were doing a project at home where they put a bunch of stuff on a shelf or something, and they just repeatedly impinged against the rotator cuff or whatever the bursa may be, and they got sore again. If it's been more than 4 months, we can use 4 months as the minimum. As soon as you give another injection, I would probably re-inject. I do have patients in my practice I see once or twice a year. They have a tight space. They get into trouble sometimes when they do stuff overhead, and we'll inject them. After maybe 3, 4, 5 injections, and they're sick of doing that, we can fix them surgically. But there's no need to do that if you're getting long relief with the subacromial space injection. The third one is they get better for a short time. This is my favorite patient, because this patient, A, needs surgery, and B, is going to do very well with surgery. So this patient comes back and says, boy, doc, that shot was awesome. For a month, I had no symptoms, but then they keep raging back, and it's too soon now, only 1 month out, to give them another shot. But they've proven to me, by getting better with the subacromial space injection, they've proven to me that my diagnosis is correct. We have subacromial space impingement, and it's reversible. We can keep things from rubbing against each other. So that's, we'll talk about what surgery we do, but that's a good patient for me. And then if they come back and they say that, boy, I got nothing out of that shot, not even in the minute during the lidocaine days, then I probably have the wrong diagnosis. I'm too vain to think that I might have got the needle in the wrong place. So I'm going to say that the diagnosis is wrong and that they've got something else. Next slide. One of the options that can sort of mimic impingement is a labral tear. There's a labral tear called the superior labrum anterior to posterior. It's a really stupid name, but the concept is that the labrum of the shoulder is this gristly ring that lives on the rim of the socket. And at about 12 o'clock, the biceps attaches the long head biceps we were talking about. And it can pull that loose and cause symptoms there. So that's an example of something that might not be impingement, but we might think it is. And if you have a labral tear, that subacromial injection not going to do anything, not even temporarily. Next slide. So let's talk about surgery. Let's say that is the patient in the third category. It's got great relief, but it was too temporary to treat conservatively. Then the next step is an operation. Next slide. And the operation is the subacromial decompression. And in that operation, we use a tool that looks kind of like a Dremel tool. You can see down here, and we just sand off the underside of the acromion to open the space. And the acromion is kind of a thin bone. We can take it almost 50% away and still have it be perfectly strong to do this job. And this next slide is just me doing that with an arthroscope. So in this picture, it's helpful to think about the shoulder as a two-story building, okay? We're in the second story here. The roof is the underside of the acromion. Floor is the top of supraspinatus. We're in the subacromial space. And I've got my little Dremel tool. I'm just kind of mowing the lawn, going back and forth like this. I've gotten to about here. You can kind of see how the bone was wangling down. There's a big bone spur here. So we're just milling that away and opening the subacromial space. So for the rest of this patient's lifetime, there's no way he's going to be able to impinge against the underside of the acromion. We've made that space just too big. At the same time, we can look at the rotator cuff and see if it's torn. So I don't need right now to really know with a preoperative MRI if the rotator cuff was torn or not. We'll go in and look surgically and have a much better idea than if we had an MRI. Next slide. So remember this picture. This is just to remind us what it's like to be in the first story of this building, which is down here. Now, in the first story, the floor is the humeral head and the roof is the underside of the rotator cuff, underside of the supraspinatus. Next slide. And these are some pictures from this scope I was doing. This is a normal shoulder, so we're looking up at the roof, and there's a sheet of tissue with no holes in it. And this is a rotator cuff tear. So I can actually see through that little dark hole up into the second story up above me. So it's not really subtle. You can find these tears with a scope, and I don't need to know, look there anyway. So I don't really need to know. As long as my patient's comfortable with the idea that we're going to go in and take off the acromion, got to do that. And then while we're there, we look at the cuff. If it's just red and angry and swollen, we're done. If it's torn like this, I got to do the extra step of repairing it. Next slide. And that's just sewing this back together. And I think one of the reasons we get MRIs is the difference in recovery is pretty vast between those two operations. The decompression alone is a pretty quick and easy recovery. Rotator cuff repair is a long and difficult recovery. So some patients really want to know beforehand. And if they really need to know, an MRI will help us predict for them which of their outcomes they're going to have. But strictly speaking, I don't really need to know when I go into it. Next slide. Let me get caught up here. All right, so let's we're run out of time. I'm not going to get too deep into glenohumeral joint problems. Let's advance. We're going to go forward, keep going. We're going to skip this instability next. There's some great things to talk about here, but we're just going to skip next. And keep going, keep going, keep going, keep going, keep going. That's a good slide. Keep going. Okay, stop here for a second. So now we're going to jump forward to the topic of glenohumeral joint arthritis. And this is a picture of the humeral head. And it's kind of hard to see on that drawing, the cadaver humeral head. But the surface of that ball is coated with articular cartilage. Next slide. I always tell patients you've seen this stuff before. It's the same stuff you can see on the end of a chicken bone, that white shiny stuff that my mom used to call bristle. We have that on the end of our